that I manage, and I would like to start by acknowledging that I'm presenting this webinar to you from the lands of the Wurundjeri people of the Kulin Nation. And I'm here in Melbourne, that's indicated on the map with a round circle. And I'll just give you a bit of background about the Melbourne Children's Campus where I work, which is a partnership between the Royal Children's Hospital, the Murdoch Children's Research Institute, the University of Melbourne, and the Royal Children's Hospital Foundation. The Royal Children's Hospital cares for the most critically ill and medically complex paediatric patients in Victoria, and it provides care to patients from other states in Australia and even sometimes to patients from overseas. We offer a range of specialist tertiary and quaternary clinical services, and together with the Murdoch Children's Research Institute are doing some innovative research with educational support from the University of Melbourne and invaluable philanthropic funding support from the Royal Children's Hospital Foundation. So this is a very strong partnership to deliver some high quality clinical services that are underpinned by research and education. I also would just mention that the genetic service at the Royal Children's Hospital and Melbourne Children's Campus is delivered by the Victorian Clinical Genetics Services, and part of my employment is through them as well. I am going to start by acknowledging up front that this program is a huge team effort, and apart from our core Rare Diseases Now team, we collaborate widely with the Victorian Clinical Genetics Services, both the clinical team under VCGS and the laboratory teams in that organisation. We work with researchers from the Murdoch Children's Research Institute, with clinicians, both doctors and allied health professionals from the Children's Hospital. We have some collaborations with the Broad Institute in the United States and the Centre for Population Genomics, which is a collaboration between MCRI and the Garvan Institute in Sydney. What I'm really grateful for in our program is to have input from a consumer engagement committee, and that we have representatives from various support and advocacy groups on that committee, and they keep us grounded and focused on the needs of our patients and their families. I also will mention that we're funded by the Royal Children's Hospital Foundation and by the Murdoch Children's Research Institute. Just to set the scene about rare diseases, there are more than 7,000 individual rare diseases, and you'll often hear people say that individually rare but collectively common, and that they affect about 2 million Australians. So about 5,000 children are seen on the Melbourne Children's Campus every year for a rare disease diagnosis. And it's not easy to get a diagnosis when you have a rare disease. It can take 5 to 10 years on average to get that secure genetic diagnosis. Often families encounter misdiagnoses along the way of their journey. Sometimes you'll have heard it called a diagnostic odyssey. Despite technological advances, some kids never get a diagnosis. And even when they do, only 5% have approved treatment options available to them. So the impact of rare diseases on families is great. There's as I've said, there's a struggle to get that accurate diagnosis and limited care and support options. But there's a lack of awareness of each individual rare disease. You know, they're, as I said, they're individually very rare. So maybe sometimes you're the only family or one of very few families in the world who have that condition, and little is known about it, and your treating team may know little about that condition. There may be a lack of research into your particular rare disease, and families can feel isolated without support from others going through a similar journey, and they often face uncertainty. So uncertain about what's ahead and uncertain about the trajectory of the diagnosis, of what it means for their family, for their other children, and for other relatives, and in particular for the affected child. So genomic testing has transformed rare disease diagnosis. But it hasn't solved all problems, and you'll see that if we take a patient on our campus, they'll present at the Royal Children's Hospital, one of the specialty clinics, either genetics or one of the other subspecialties. They'll be assessed, and it will be determined that they have a likely monogenic condition. A genomic test will be ordered either by the genetics service or by one of the other specialty services, and in 50% of cases we'll achieve a diagnosis with that clinical test, but in the other 50% those patients remain undiagnosed. So what to do? What we did was to establish a program on the campus called Rare Diseases Now, or RDNow. And this grew out of a pilot project called the Undiagnosed Diseases Program Victoria, or UDP-VIC. And UDP-VIC was focused on kids on our campus, but only from the genetics service. And we felt that if we opened up eligibility to patients from any department within the hospital, we're giving opportunity and access to a broader range of patients and families. But also we have the capability to address some of the challenges on campus when working with rare disease. So, for example, we can look at how to solve some of the challenges on campus, and how do we tackle the barriers of moving sequencing data, for example, from the clinical space into the research space, and how can we shepherd patients in a systematic way from diagnosis to potential clinical trials and therapies. And so we have a vision on our campus to work with our campus partners and other global and national initiatives to enable all patients living with a rare disease to receive a precise diagnosis, optimal care, and access to innovative research and therapies if available. And as I mentioned before, we have 3 different pillars to our mission, and I'm going to talk a little bit about them, what we're doing to address them, and towards the end of the program, as Norma mentioned, that she's her interest is in workforce, that she asked me to talk a bit about upskilling the genomic workforce, and I'll do that towards the end of the talk. So let's have a look at discovery in the program. And I'm going to take you through our cohort who, since 2020, we've been referred 232 patients to RDNow. And to be eligible for inclusion, you need to be referred from one of our specialty outpatient clinics. I've said pediatrics there, but sometimes we can open it up to to adults where needed, and you'll see that on some of the next slides, that there needs to be a likely monogenic cause for the condition, and that patients remain undiagnosed after usual clinical genomic testing or genetic testing. So sometimes we don't require that exome or genome testing has been done, but often it has been already. We also consider families where there's been a single variant identified in an autosomal recessive condition, and you'll see that in an example I'm going to talk about soon. We evaluate every patient who's referred by our clinical working group, and that group consists of our clinical geneticists, the genetic counsellors in the team, me, our PhD students who are medically trained, and we also invite the variant analyst to that meeting so for their information, and so that they have a good background in the patients who are coming through the program. We also had some patients who, after going through the pilot UDP-VIC program, remained undiagnosed. So we've offered them further testing through RDNow. Of those two groups of patients, 46 were excluded because after further deep phenotyping, we then thought, the clinical geneticists thought, that it's unlikely that there's a monogenic cause for their conditions. Sometimes we didn't have a test to offer. Everything that we could offer had already been done. Sometimes they're already enrolled in another research program who's doing similar testing to us, and we don't want to double up. A few families have declined further testing for various reasons. That, like I talked about, the diagnostic odyssey, because it's long. Sometimes people have had enough. They don't want to go further. Some patients are lost to follow up. We've had referrals for people who are not from the Royal Children's Hospital and are ineligible because of that reason. Or sometimes a diagnosis has been identified before we have a chat to them about the RDNow program and get their consent to participate. So to date, we've got about 287 patients enrolled in RDNow, and they are at various stages along the pathway from just having consented to having completed all testing we can offer them. I want to give you a little bit of a flavour of one of our patients who has come through RDNow, and we had this little one referred to us from the metabolics team, and he, little 10-month-old boy with hypertonic, who was hypertonic, has developmental delay and macrocephaly, and the leading differential diagnosis was Canavan disease, which is an autosomal recessive neurodegenerative white matter disorder. And this particular condition is associated with a complete loss of an enzyme called ASPA. The gene ASPA is the only gene associated with this particular disorder. And this little boy had clinical genomic testing at one of the other major children's hospitals in Melbourne, and the testing was inconclusive. So what was identified was a missense variant in the ASPA gene, and it was maternally inherited, but we didn't know what was affecting the paternal allele that had been unidentified, and the clinical teams were unsure where to go next. So they referred to RDNow. And because we are research funded and have flexibility, we can design a bespoke analysis program for every family who enters the project. And it could be that we reanalyze existing clinical data. We might take a singleton exome or genome and do a trio, so look at the parents as well as the child. We can do a combination of genome and RNA sequencing. We have links into research groups who are doing functional genomics, and as I'll show you later, we are developing some other multi-omics strategies to increase our diagnostic yield. So with our little patient, what we thought would give us the best chance of identifying that paternal variant was trio genome sequencing and RNA sequencing. The metabolics team, in the meantime, ordered a clinical high-resolution chromosome microarray in case there was an obvious chromosomal rearrangement or deletion insertion that could be seen on an array, and that would be faster to identify that way than the genome and RNA sequencing we were offering. The metabolics team also organised a skin biopsy for fibroblast culture, because usually we use blood for our genome and RNA-seq, but this particular gene is poorly expressed in white cells and lymphoblast cell cultures. So we were keen to have fibroblasts in case we needed them. And what did we find? Unfortunately, the chromosome microarray was uninformative. And so we went on to look at the genome data in a platform called Seeker, which some of you may be familiar with. It's an analysis platform where we can do research, genomic analysis. And on that, it really good for picking up small variations with but with that program, all we identified was the maternally inherited missense variant again. And at that stage, our amazing bioinformatician, Dr. Katrina Bell, came back to us and said, look, I can't see anything. Are you sure it's this condition and it's this gene? And the clinical team were very sure. So we went back to her and said, look, we're certain this is it. Can you, is there anything else you can do? And she did some very detailed manual searching and identified a DNA fragment that was inserted deep intronically in the ASPA gene. She recently talked about this case and said that when we said to her, it's definitely this gene, it was quite the bonus, because it meant that she could really narrow her search and not have to look at the whole genome, but knew what needle to look at in the haystack of needles. This result was great for the family, because what they were searching for was that second hit in the autosomal recessive gene to enable eligibility for this little boy into a clinical trial. So they had that answer, and they could go ahead with that next step for him. For them and for us, we wanted to prove causality of this intronic insertion. So we continued with the RNA sequencing analysis, which was it was very much trickier than we thought it would be. And we were unable to prove anything with the child's samples, because he did not express the gene in any of the samples we had available. So we went back to Dad and we asked Dad, because it's a paternally inherited variant, can we have a skin sample from you so we can try directly extracting the RNA from your skin, and we can set up a cell culture, and we can sequence the RNA from the fibroblast cells. We can treat them with cyclohexamide and see whether to look at the difference between nonsense-mediated decay strands and those that are the cyclohexamide prevents that. So we, you know, of course, Dad's very keen to do anything to help, and one of our very lovely clinical geneticists took a skin biopsy from him, and through looking at Dad, we were able to confirm that that second hit really did affect mRNA assembly, and that was the causative variant, causative second hit. So I talked about the impact of rare diseases on families in general, but what was the impact on our family in particular? And well, like I said, this provided eligibility for clinical trial, and it's given the parents some reproductive options for the future. So I'm going to zoom out again to our cohort overall, and what does it look like? It's we have a bit of a skewing of males and females, so almost 40% females and just over 60% males. And we think that's because there are a lot of the conditions we see are neurodevelopmental, and there tend to be more boys in that bucket than girls. If I compare that to the patients we normally see in the genetics clinic, those ratios are quite similar. Our median age of participant is 7 years. We have a couple of adults over to the right of that plot, and they are enrolled because they're parents of children whose samples were inappropriate or inaccessible. So the parents have been proxies for testing to get a diagnosis for the child. In almost 16% of families, there is more than one affected relative, and we have about 13.5% of families are consanguineous, and sadly, some kids are deceased, but their families would still like an answer to know what happened and to inform outcomes for other family members. I mentioned that our pilot project was just concentrated on the genetics of patients who came through the genetics department, and RDNow has opened up referral from other specialty departments on the campus. So you can see that most patients from non-genetics departments are from neurology. There's some from general pediatrics and some from metabolics, like our little boy that I talked about before. As I mentioned, most kids have a neurodevelopmental disorder, either plus or minus dysmorphic features, and there's some other few metabolic conditions, some multi-system disorders, some single system disorders, a bit of a range of phenotypes. Even though we have great advances in genomic medicine, the trajectory through RDNow is still long, and it's about a year from time to consent to getting a diagnosis. So each of those blue bars shows the number of days for that patient to get a diagnosis from the day they consented to the day we had something to tell the parents. And the ones on the left-hand side of the graph are the patients who came through the UDP VIC program. So they're the ones who were undiagnosed when even after testing through that pilot program. So they would have consented at the beginning of that program, and then their consent carried through to the RDNow. And so they've been with us for a long time before we were finally able to get a diagnosis for them. What are our outcomes for the discovery part of our program? Well, we've completed testing for 110 families now, and in 52% we've diagnosed them. So you'll remember at the beginning I said that 50% were undiagnosed, so that undiagnosed cohort have come to us and we've been able to diagnose half of them. And those diagnoses have sometimes been in known genes, missed for all sorts of reasons. Maybe the right test wasn't available, or the wrong gene list was looked at originally. The phenotype evolved and we knew to look further. Some of them are novel gene discoveries, and you can see in the animation below some of those gene discoveries, and also phenotype expansions for genes. They're all in that animation. Sometimes there's been a copy number variant. We've had some mosaic disorders, a deep intronic single nucleotide variant in some cases, and retrotransposon was identified. So where to from here? We're with the genomics testing that we have in place at the moment, genomics and transcriptomics, we're getting a diagnostic yield of about 50%. But how can we improve that? So we're doing that by engaging with other teams around Australia and internationally. And these are some of the programs that are just starting this year and into next year, with the aim of improving our diagnostic yield. So our genomic sequencing has been short read sequencing up until now, but we now have a nice project funded by the Australian government with Dr. Ira Devison at the Garvan Institute in Sydney to do some long read sequencing, so we can do genomic sequencing on bigger fragments of DNA. And we are using that to clarify those patients who are what we're calling half diagnosed, so where we have part of the answer to the story, can doing long read sequencing complete the picture. So where we can't, sometimes we can't tell whether biallelic variants are on different alleles, and maybe that's because we don't have availability of both mum and dad to sort that out. This is a technology we can use for that. We also have some patients who have had every test we can think of, and we're trying this as a last resort for them. As you saw in our case study, we do transcriptomics, so we do a combination of genomics and RNA sequencing with in collaboration with the Centre for Population Genomics. So that's that collaboration between the Murdoch and the Garvan Institutes. And our PhD student, Dr. Smitha Kumble, is working on that mainly. She's leading that program. We have a nice collaboration with Professor David Stroud at the University of Melbourne. And she is, and he's working on a proteomics study where we might have a candidate variant of uncertain significance, and we can look at how the proteins are working together, how the complexes are working together, or whether the individual proteins are affected by genetic variants. We have some methylomics programs just starting, looking at episignatures, and we are also hoping to implement metabolomics for some of our cases. So they're the things that are ramping up in the coming year, and we're hoping that will help our patients to achieve a diagnosis. So just to summarize what happens in the discovery part of our program, a patient comes along with a negative clinical or uninformative clinical test. We develop a bespoke analytical pathway for that patient and family, and that may require some work, some sharing of data or samples with other collaborators. And when we have a diagnosis, we'll send it off for clinical validation in the diagnostic lab before returning the result to the referring doctor, who will then return the result to the family. And I mentioned at the beginning that with Nirmala's interest in education and workforce education, she asked me to talk a bit about what we're doing in that regard within RDNow. And we do some research training for postgraduate students, like master's students and PhD students. But we also have a genomics immersion fellowship program ongoing, and I'm going to just spend the rest of the time talking about that in a little bit, not too much detail. So we fund a program to train physicians from specialties other than genetics. So these are advanced medical trainees who want an experience in genetics and genomics but don't intend to be clinical geneticists at the end of their training. They want to specialise in another area, but we wanted to offer them the opportunity to immerse themselves in rare disease research. So our first cohort spent 6 months with us, and their feedback was that was not long enough. So in the next rounds, we offered 12 months fellowships with the Victorian Clinical Genetics Services, but working with the RDNow team. And so, as I said, embedded in the research centre, and they learn skills aligned with mainstreaming genomic medicine, diagnosis and management. They have the opportunity to attend our educational meetings, our what we call multidisciplinary team meetings, where we discuss the results from genomic testing and prioritise variants, organise the next steps for those patients. They come to all of those. They can come to our clinical working group meetings, and they can go to any clinical lectures or workshops, symposia, other meetings. They work with the consultant clinical geneticists and the genetics fellows who have that pathway towards becoming clinical geneticists, and work in clinic with them. So they do clinical assessments of our patients, and they also have the opportunity to learn curation of genomic variant analysis. We ask that they develop a genomic-based resource that's relevant to their primary specialty, so they can take that back to their home team and share that and enhance the team's knowledge. So we want them to gain skills that can be incorporated into their specialty, and we also want them to disseminate the knowledge they've gained to their peers in their home subspecialty. Our fellows range from early trainees to quite senior trainees, so junior consultants. They come from a variety of specialty areas, like the doctors in that picture, and like the doctors in the picture. We've had 8 fellows so far. They have said that they have had limited genomic testing during their training, but they've everything they know they've picked up through experience in their clinical work. So far, we've had people from oncology, from neonatal intensive care, hematology, metabolics, and general pediatrics. So, what have they said to us about their experience? Pleasingly for us, it's been quite positive. They've their confidence has improved. Their genomics confidence and literacy has improved. They have a greater understanding of the clinical approach we take in genetics, and the different indications for ordering certain tests and following certain analysis pathways. But, you know, I meant to say that this evaluation of the fellows was done by Smith, our PhD student. And when you ask people to evaluate a program, then sometimes some of the things that are a little bit challenging to face and to digest and incorporate. But they also mentioned that it's hard. There's a high clinical workload expected, and in genetics there's quite a lot of administration involved with ordering the tests and organising samples and consent and etc. So some of those things are not what they encounter in their home specialties. As I said, the first tranche of fellows said that the fellowship wasn't long enough, so we've changed that, and we'll be interested to see whether 12 months is better. There've been a little bit of challenges in the beginning, working out what our expectations, what their expectations are of the experience. So that's something to clarify in the future. And it can be tricky balancing roles between the clinical work and the research work. So as they're embedded in the clinical team, they're expected to have a clinical workload, and we're also saying we want you to do a bit of research as well. So that can be a tricky balancing act. And I now want to come back to our team and just thank them all again. That it's a very lovely group of people to work with. These are people within the core team, past and present, but also from the extended team. And a lot of people put in their time and work with goodwill to make all of this happen. It's been a good learning experience for me to meet a lot of people around the Institute and to learn how things in different areas work. So from, learning the lab processes so that we can make sure that the way we provide samples to the lab and information to the lab works for them, so that they can help us working with the tissue culture team so that they get the samples they need in a timely manner and can set up cultures for us that we need to analyse. And in particular, a big shout out to the bioinformatics team, who without them we wouldn't have the data that we need to analyse things, and they've really worked hard to streamline transfer of data, which naively, when I went into this, I thought it's just like, let's drag and drop a file from place to place, but it's not that. It's very complicated. And they've worked really hard to get that streamlined. And so with that, I would also like to thank you all for listening and invite any questions. Thank you.
Okay, thank you, Michelle, for that insightful and exciting talk about the RD program. The floor is now open for any questions from the audience. If you have any questions, you can ask or you can drop it in the chat. And I think Michelle will be glad to answer them. So maybe, Michelle, we'll start off with a couple of questions. So you talked about the diagnostic pathway and then arriving at a diagnosis finally, which I think is a relief to the whole team as well as the family. So in situations where the diagnosis is established and there's a potential cure, treatment options are available. So what is the pathway generally like? The treatment, is it funded by the hospital? And what are the options for them to get into clinical trials? If you can just briefly mention on that.
Yeah, clinical trials can be hard. It's they're like we've alluded to, they may not be available, but if they are available, then it depends a little bit on the trial. So thinking about the case study that I showed you, if that child takes up the clinical trial, he'll need to travel to the United States for treatment. So that is often at the expense of the family. So it's hard, or at least partly at the expense of the family. We can sometimes get compassionate access to drugs at the hospital. So some of those treatments are funded by the hospital or through philanthropy, or the drug companies will fund them. So there's a variety of ways. We try wherever we can not to push the costs back on the parents, but sometimes it's unavoidable. But yes, after they've come from RDNow, we'll give all that information back to the clinical team. Sometimes it's a bit of a fuzzy overlap, because sometimes some of the RDNow doctors are the clinical treating doctors too. So for the patients, sometimes there's a lack of clarity about who does what, but the information goes back to the clinical team, and then they take over the care once we've found a diagnosis.
Then probably another question regarding like the novel variants or the VUS that you normally come across quite often when we do the genomic sequencing, and especially like in our situation, like from LMICs, where there's underrepresentation of our variants in the population genomic databases. So what would you sort of advice regarding the next approaches in terms of the functional genomics that would be offered to these patients?
Yeah, so often we'll submit those variants to Matchmaker Exchange or one of those other databases, and look for matches and establish a connection with often the connections are with groups overseas, and we'll send samples to those groups for further testing. We have an initiative called the Australian Functional Genomics Network that's Australian government funded, and sometimes they can do some functional studies on those variants. It's not straightforward. There's not one way, but it's just looking out there and trying to find somebody who's interested in working on a particular variant and will be willing to look at our patients as well.
So do we have any questions from the participants? You can please ask your questions, or you can drop it in the chat.
Good morning, Michelle. Thank you for that discussion and the presentation about your cohort. I noticed that the cohort split was 60% male, and that's boy children, versus, and I was just wondering about the that split, because typically volunteer cohorts are more skewed towards women, at least in the US. And I understand that this is based off of a clinical disease and something that's manifesting, but is it possible that it's more of the families of the boys that are coming forward rather than the families of the girls? Do you get that sense of who's actually coming forward to volunteer?
So the patients are referred by their treating doctors, although, you know, we're not forcing anyone to do this. So they have to be, the families need to be willing and interested in finding a diagnosis. And it's a bit more like doing, it's more like clinical testing, but via research funding. So it's a bit different to volunteer research, I guess.
Okay.
You're right. Whenever I do any other kind of research, looking at qualitative research, for example, with families and parents, it's always the mothers who are volunteering, and we get very few dads. I think this is because it's that clinical basis that we get that split that's a bit different to other research.
Okay. I didn't know if there was something that was a little more on a basis of families or clinicians or families are coming forward with more of the boy issues and trying to figure those out rather than the girls. So more of a who's prioritized, and that gets into deeper issues about culture and society.
Yeah, I know what, I understand what you're getting at. I guess unless our clinical genetics department as a whole is getting more boys for that reason as well, because it really, it's sort of a similar split to our clinical cohort and this research cohort. Okay. But it could be that then things like neurodevelopmental conditions, if they manifest differently in boys, and that's perceived as perceived differently to how it is in girls. So it's interesting to look into that.
Okay, thank you.
Okay, I think there's a question from Beatrice about sharing data in public databases. Whether you share?
You share your data in public databases. Not really. And I think that maybe there are people in the audience who can correct me if I'm wrong, but I've got a feeling that the clinical lab shares all the genomic data in public databases after a certain amount of time, but the research data is not released in that way. We don't have ethics approval to do that, but I understand the benefits, and and especially for rare diseases, with the Centre for Population Genomics, which the partnership between the Murdoch Children's and the Garvan Institute, they are building a cohort data of rare disease genomic sequencing, and especially of underrepresented ethnicities. So that's a way we share our data, but otherwise we don't have that ethical approval to do that. But yes, actually, the Murdoch Children's has has quite a strong linkage with GO4GH, so where we have connections there. Yeah, ethics and legal, that there are issues with sharing data as well.
Okay, Michelle, maybe one last question before we round off. I think that the genomics immersion program that you mentioned is an excellent initiative to train the non-geneticist physicians. So like this program, is it open only to the local trainees, or are there any plans to open it up to international participants in the future?
No, it's a local one. I know there's at least one person from Melbourne Genomics Health Alliance online, and they are doing a lot of work in upskilling genomics health professionals. So their work is broader than ours, and also the Australian Genomics have done some educational work, but we don't have plans at the moment to expand it beyond the hospital, unless we're just in the process of applying for future funding, and we're in that next iteration of RDNow. We're thinking of offering like not exactly fellowships, but stipends for people who want to come in from externally and spend some time with us.
Okay.
Yeah, so I can keep you informed if that gets off the ground.
Yeah, that's great. I think a lot of people would be interested. Yeah. Okay, so I think we had an excellent discussion today, and thank you so much, Michelle De Silva, for sparing your time out of your busy schedule, and I know it's way past your bedtime now. So thanks for participating, and thanks everyone for joining this webinar today, and I'll hand you back to Latifa for the final words.
Thank you. Thank you so much, Dr. De Silva, for this insightful presentation, and Nirmala for moderating the session. I put in the chat box the upcoming webinar that is coming in November. I will provide more information on the dates and the talk. So thank you again, everyone, and see you on the next webinar. And have a great evening, great day. Bye-bye.
Thanks, Michelle.
Okay,
Thank you.
Thanks.
Thank you.
Bye.
Thanks.
Bye.
Bye.